Thank you very much, Dr. Junaid, for giving me this opportunity. Today I'm going to talk about post-hemorrhagic ventricular dilatation management in preterm infant. And the objective which I have got is really, I just want to identify what's the current practice of management of post-hemorrhagic ventricular dilatation at international level. And then I want to discuss the evidence behind this clinical practice. I have also tried to get some information about the ongoing local clinical practice and then comparing it with current international clinical practice and what we can do. So we all know that severe intraventricular hemorrhage is it affects about 15% of extremely preterm infants, and about 1/3 to half of patients with IVH do develop post-hemorrhagic ventricular dilatation. And then again, about 1/3 of this progressive post-hemorrhagic ventricular dilatation, they do need intervention at about 35 to 40% of this group of patients. But presently, there is no any consensus about the management of this this difficult area of management. Before I go into further details, there one slide about the intraventricular hemorrhage. There are 4 grades of intraventricular hemorrhage. Grade 1 is subependymal bleed. There is no much bleed within the ventricles, but in grade 2, you can see the blood clots within the ventricles, but the ventricles are not filled with more than 50%. Whereas in grade 3, you can see the intraventricular bleed clot very obvious, and it will be filling the ventricle more than 50%, and the ventricles may or may not be dilated. Whereas the grade 4, which is more termed as post-hemorrhagic parenchymal infarction rather than grade 4 IVH, where the bleed is seen in the brain parenchyma. Usually the hydrocephalus is about abnormal buildup of CSF in the ventricles of the brain. And physiologically, the head circumference or the brain growth happens about 1 millimeter per day between 26 to 32 weeks. And after that, the growth slows down a little bit, about 0.7 millimeter per day up to 40-week gestational age. Enlarging ventricles within the brain, we can measure them by measuring the anterior horn width and the ventricular index on the cranial ultrasound scan. Whereas the anterior horn width is the diagonal distance between the 2 walls of the lateral ventricles, whereas the ventricular index is the distance from midline to the lateral wall of the lateral ventricles. And these measurements are usually done on a coronal view at the level of the 3rd ventricles. Once we have done the ventricular index measurement, they are usually plotted on the Levine chart. The dashed black line indicates the average ventricular index, whereas the dashed red line is indicating the ventricular index at 97th centile. This is the point where we really start monitoring the ventricular dilatation more closely. Whereas this solid red line is showing the ventricular index at 97th centile plus 4 millimeter, and this is the point where people start intervening or start to drain the CSF from the ventricle because the ventricles are too much dilated. Whereas the anterior horn width, which we have measured on the cranial ultrasound scan, is plotted at the Davis chart. This interrupted or dashed black line is indicating the mildly dilated ventricles, whereas the anterior horn width at the level of the red line showing the moderately dilated lateral ventricles, and the solid black line is showing the severely dilated ventricles. There are ways to monitor and decide about intervene when the ventricles has dilated post-hemorrhagically. So we can use the head circumference measurement or ultrasound ventricular dimensions measurement, which we do like measuring ventricular index and anterior horn width, or we can look at the clinical signs of raised intracranial pressures. And then one option is you use them all together. So these are the different ways of monitoring the ventricular dilatation. And people have tried to look at the relationship between the intracranial pressure and the ventricular size. And what they have found is that there is a positive relation between the ventricular size and the CSF, but it has not got much association with the clinical signs. And the reason behind is that usually the CSF pressure is around about 9 millimeter mercury. It starts increasing the ventricular size, but the clinical signs usually come up when the CSF pressure goes up to around about 15 millimeter mercury. And similarly, they did not manage to find any relationship between head growth and the CSF pressures. People have also tried to look at the relationship between the head circumference and the ventricular size measured on cranial ultrasound scan. And they could not find a relationship between the head circumference and the ventricular measurements done on cranial ultrasound scan. And the reason possibly is the brain parenchyma in these preterm infants is really very, very compliant. And then there is a lot of extracerebral space available. Coming to this review article, which was published in 2012, the author, Andrew Whitelaw, he recommended that at the moment the standard and the widely used approach is to use the ventricular tap, to use the ventricular reservoir device to drain the ventricle. It is quite standard and widely used approach. And in this approach, the intervention is decided by clinical signs suggestive of raised intracranial pressure, and then the ventricular measurement, which is done on head ultrasound scan. It is followed by doing the LPs, and if the patient needs more than 3 or 4 times LP, and the ventricles are still getting bigger, they use the ventricular taps. And at this stage, they usually put the ventricular access device. And they have seen that this approach is quite okay or appropriate for extremely low birth weight infants, less than 1 kg, and in the neonatal setting. In the same review article, they have discussed about other management approach to post-hemorrhagic ventricular dilatation, like use of diuretics to reduce the CSF productions, but it has not been supported very well by the randomized trials. And then coming to the intraventricular fibrinolytic therapy, or is a part of a drift trials, but in order to implement that approach, really you need very skilled setting. So it is not easy to implement in a neonatal setting. And the other approaches like external ventricular drain, ventricular subclavian shunt, or third ventriculostomy, or co-right fluxus coagulation. There is no much lot of evidence behind these different approaches to drain the CSF in post-hemorrhagic ventricular dilatation. And in around the same time, a center published their experience of managing such patients who has got post-hemorrhagic ventricular dilatations. And they published their experience over the 20 years, and they were about 295 patients. A majority of them were preterm and significant IV and having significant IVH. These were the same patients which we are coming across in our neonatal unit. And they were treating them with temporary treatment with lumbar puncture or puncture from the ventricular reservoir, which was inserted. What they have found that ventricular reservoirs was inserted in about 73% of patients, and the overall infection rate was quite reasonable, about 6%, and the VP shunt was inserted in about 1/3 of the total cohort. So they have a good experience of managing such patients. And the same group, really, they published one article which was more a running commentary, where they were doing the amplitude integrated EEG, or the visual evoked potentials uh, before and after insertions of ventricular access device. But they were trying to reproduce the same results which were claimed by another group of investigators, but they were not successful. And what the people who are recommending that we should do not do intervention only when the infants are symptomatic in case of post-hemorrhagic ventricular dilatation. We should consider ventricular index measurement when it is 97 centile plus 4 millimeters, and the intervention should be aimed to reduce the ventricular size down to normal limits, and the caps should not be performed just to relieve the raised intracranial pressure. In order to have a little bit bigger picture that what's happening at a bigger scale, then this survey was completed across Europe, where they tried to find the diagnosis and treatment approach of post-hemorrhagic ventricular dilatation. And they did that survey with the help of a questionnaire, and they contacted about 32 neonatal intensive care units across 17 countries. And what the nutshell was that, yes, the diagnostic and therapeutic approach to manage this PHVD it does vary, but the majority of the center initiate treatment once the ventricular index has crossed the 97 centile plus 4 millimeter. And when we having a closer look, that there were about 7% of the patients were having severe IVH, like grade 3 and grade 4. And about half of them developed a post-hemorrhagic ventricular dilatation. And then really 1/3 did not need intervention, and about 2/3 required intervention. And if we see what the diagnostic criteria they have used, most of them were using ventricular index reaching more than 97 centile. But some units were also using when the ventricular index was more than 97 centile plus 4 millimeter. And if we look at what was their criteria to start intervention, there were two major groups. Either they were doing early intervention or they were doing later intervention. Where early intervention means that they start draining the CSF from the ventricles when the ventricular index is at 97 centiles, or taking other measurements. Whereas in late intervention, most of the people who are draining CSF or start intervening it when the ventricular index is 97 centile plus 4 millimeter. Or some centers were doing it when it is associated on top of that when the patient is having clinical signs suggestive of raised intracranial pressure. In terms of treatment modalities, really, the most of the people were using the same kind of approach which I mentioned in the review article, that they were starting with the lumbar puncture, and then they were doing ventricular tap, and then they would insert if it need more frequently, then they bring up ventricular reservoir, and then if it continue progressing the ventricle size, then they can use ventricular peritoneal shunt. There is a group of investigators who were using the drift trials, but obviously you can see it is being practiced only in 2 units, so it is not easy to implement. And then in another study, people have tried to look at the outcome of patients having post-hemorrhagic ventricular dilatation, and in this group, they looked at the outcome of patients less than 26 weeks gestational age, and really they divided them into three main groups. Either they were having post-hemorrhagic ventricular dilatation seen on a head ultrasound scan, or they have got intraventricular hemorrhage, but the ventricles are not dilated, or they do not have the intraventricular hemorrhage. And the conclusion was that post-hemorrhagic ventricular dilatation was associated with high rates of death or impairment among infants with gestational age less than 26 weeks. An interesting risk was further increased among those with progressive ventricular dilatation requiring intervention. And then this randomized controlled trials was published in 2018, where they randomized the patient when the ventricular index is at 97th centile. They randomized them to early intervention or the late intervention. In terms of early intervention, when the ventricular index was at 97th centile and the interior horn width was more than 6 millimeters, they started intervening. Whereas in later intervention, this was when the ventricular index was 97th centile plus 4 millimeter and the interior horn width was more than 10 millimeter. And the intervention-wise, they were doing lumbar punctures initially. If patients still having progressive ventricular dilatation, then they put the reservoir and tapping the ventricles through this reservoir, and if it does not settle down and patient continue having ventricular dilatation, then they get the ventriculoperitoneal shunt when they reach to at certain weight. And really the outcome of this randomized control trial was that there was no significant difference in terms of ventriculoperitoneal shunt or death in these two groups of patients. Either they were treated by early intervention or later intervention. The same group, then they tried to look at the brain injury and the brain volumes in this group of trial, in this patients in this group, and they did the sub-study. What they did MRI scan at equivalent age in these patients, and then they tried to score the brain injury and the brain volume using Kidocor score. And what they found that the Kidocor score was lower in low threshold group, which means it was normal or mildly increased, comparing with it was higher in higher threshold group, which was moderate or severely abnormal score, and the p-value was also significant. And they also found the ventricular CSF volumes were smaller in lower threshold groups. So the conclusion of that study was there were more brain injury and larger ventricular volumes demonstrated in the high versus the low threshold group. So these results were supporting the positive effects of early intervention for post-hemorrhagic ventricular dilatation. And the same group of patients in the ELVIS trial, they tried to look at the neurodevelopmental outcome at 2 years of age. And when they looked at the they calculated the cognitive score and the motor score. It's one thing which clearly come up that the patients in the low threshold group having better cognitive and motor score compared to those who were in the higher threshold group. And interestingly, they also divided them those who needed a shunt and those who do not need a ventricular peritoneal shunt. And the patients within the low threshold group having almost normal neurodevelopmental outcome. But patients in the higher threshold group who need a ventricular peritoneal shunt, they were having the worst neurodevelopmental outcome. In conclusion, that the earlier intervention was associated with lower odds of death or neurodevelopmental disability in preterm infant with progressive post-hemorrhagic ventricular dilatation. And then it comes up a meta-analysis was done, which was recently published, and they try to relate the timing of temporizing neurosurgical treatment in relation to shunting, ventricular peritoneal shunting, and neurodevelopmental outcome in the post-hemorrhagic ventricular dilatation. The aim was really to see if there any relationship between these, and what they found that the later timing of this temporizing neurosurgical procedure, it predicted higher rates of conversion of ventricular peritoneal shunt and moderate to severe neurodevelopmental impairment. And they use this graph to explain their finding. If you see that the later the initiation of temporizing neurosurgical procedure was associated with higher rates of ventriculoperitoneal shunts. And then they found the same kind of relationship between the neurodevelopmental outcome and the later initiation of the temporizing neurosurgical procedure. And then this study came up where they tried to look at the neurodevelopmental outcome in the same group of patients, those who were having post-hemorrhagic ventricular dilatation, and they were managed either by early approach, which means the intervention started when the ventricular index is at 97, above 97 centiles, or the late approach when the ventricular index is 97 centiles plus 4 millimeter. And they look at the preterm infant less than 30 weeks, a total about 127 and 78% in early approach and 49%. And what the conclusion was that those early approach group, even when they're requiring a shunt, had outcomes similar to those without intervention and being within the normal range. Whereas in late approach group, they need intervention predictive of worse outcome. And the benefits of early approach was really outweighs the potential risk. And if we look at their neurodevelopmental outcome a little bit closely in the same population, that most of patients who were having early approach, most of them were having quite high neurodevelopmental outcome, close to normal. And whereas we see those who were managed with late approach with intervention, their neurodevelopmental score, they were having maximum number of patients with moderately abnormal neurodevelopmental outcome. And if we see at the cognitive and the motor score, it is almost near normal in patients with early approach. Either they are without intervention or they having the intervention. Whereas in those managed with late approach with intervention, quite worse outcome. And then the impairment like having cerebral palsy, hearing impairment, vision problems, and epilepsy. There were maximum number of patients in those who had late approach and having intervention. They also tried to relate the neurodevelopmental outcome with the ventricular size. And there was a clear relationship between the ventricular size and the neurodevelopmental outcome at 18 to 24 months of age. What they compare was in patients in North American population where the patients are managed with late approach. They try to compare their neurodevelopmental outcome with patients in the ELVIS trial. Either they were managed with early approach or they were managed with late approach. And there is clear apparent, that's clearly obvious that the patients who were in North American group, they were having a lower motor and cognitive development. And if you look at the ventricular size, patients who were managed in the ELVIS trial, even they managed with the late approach, the ventricle size was much smaller compared to the ventricular size in North American population. So all this evidence is supporting that we need to avoid the largest degree of ventricular dilatation. Now, at the same time that after going through this, I tried to get some idea about the ongoing practice in UAE. And then what I did, I spoke to main tertiary level neonatal unit and spoke to the chief. I collected some information about the management of post-hemorrhagic ventricular dilatation in extremely preterm infants. So if you look at this data, there's no much difference between the incidence of severe IVH and the rate of developing post-hemorrhagic ventricular dilatations. But the interesting thing is almost all the units having very minimal number of cases to manage. So that might be related that it might be difficult to develop the skills which are necessary to manage patients with such problems. And if we see at the diagnostic criteria, then again the diagnostic criteria is related to being symptomatic or uh, late approach, which means that the ventricular index is 97 centile plus 4 millimeter, or the head circumference is increasing more than 1.5 centimeter. And the intervention threshold, again, most of the centers were treating symptomatic patients, or if the ventricular index has reached to 97 centile plus 4 millimeter, and the head circumference is going faster than 1.5 center. And the CSF drainage modality which they were using were, again, most of them were doing the ventricular tap directly, or if they have got the arrangement, they insert the Ommaya reservoir. If the still ventricles are getting bigger, then they get the ventriculoperitoneal shunt. And then most of the centers are not having the neurosurgeon arrangement in the same hospitals. So recently, comparing all this, recently a framework to approach such a problem has been published, which has been agreed by most of the people who have been managing this problems over years. And this framework is based on measuring the ventricles on cranial ultrasound, and then also taking into considerations of clinical signs of raised intracranial pressure. And then they also look at the head circumference growth as well. And based on that data, they were dividing them into 3 groups, either zone green, yellow, and red zone. And then they follow the recommendation. And that seems to be well supported by the evidence that when we are treating patients with posthemorrhagic ventricular dilatation, the cure should help them to get a better neurodevelopmental outcome. So what we should do, I really leave that to decide with you guys that how we should manage posthemorrhagic ventricular dilatation in this region. But what I think that we really need to have a multidisciplinary team approach. We need to agree on one clinical practice, and the one clinical practice which is well supported by the evidence is to monitor the dilated ventricles with cranial ultrasound, taking into account clinical signs and looking at the head circumference as well, and then following this framework. And again, most of the centers haven't got enough number of patients, so the patient need to be referred to one center, and that center will have enough patients to develop the skills and manage the patient with one recommended approach. Thank you very much for having me. I'm happy to answer any questions if it comes up.